Thank you, Dr. Kerr. We're now off schedule already. Okay. No, I'm sorry. He'll be here all day if you have questions for him, and I'm sure he'd be happy to talk your ear off about this work. Okay, so we will forge onwards now. So it's a pleasure to introduce Dr. Charles Levy, who's the Chief of Physical Medicine and Rehabilitation at the University of Florida at Gainesville, and been part of the TMA for a long time. And I'm not going to read his title, it's lengthy, and he's going to tell us about a lot of things going on. Thanks, Dr. Levy.
Good morning. I'm really delighted to be here. It's hard for me to express how gratifying it is to see the growth of the Transverse Myelitis Association, and also kind of the complementary and independent growth of research into transverse myelitis. And many of you I've known for many years. Some have been with me, and I've been with you really since the start of this, and others are people who I've gotten to know along the way. And anyway, I'm so gratified. It's so exciting to be here, and I'm grateful for all the organizers, all the other investigators, and I will do my best to present to you stuff that I think is going to be interesting. I have way too much to present, and so my solution to that is to talk real fast and flip a lot of slides. So let me start with that, see if I can figure out how to flip them. Basically, when I saw you last was in Seattle, and I was at Ohio State then, and now I'm in Gainesville, Florida. I'm Chief of Physical Medicine Rehab at the VA, and the VA has been very good to me, and I want to acknowledge that. And I also have an appointment at the University of Florida. So let's get started. I'm going to present work of others, and in each of these projects I have some roles. Some I'm primary, one I'm primary, and others I'm kind of on the periphery, and others I'm more secondary. The first project, so I want to acknowledge directly Dr. Worth, Dr. Behrman, Dr. Martin, and Dr. Rogers, and you'll see their work as we go along. So the first work I'd like to talk about is a study by Dr. Worth and his colleagues, Neural Tissue Transplant in Syringomyelia, Feasibility and Safety. And this is the acknowledgement slide that Dr. Worth presents, so I'm going to present it in his place, and now I'm going to move along. The primary goals of this study was to see if it would be feasible, if it would be doable, and if it would be safe to implant fetal cells in human spinal cords in live walking or not so well walking people. The people that were selected were people who had spinal cord injuries in a chronic phase and who had a syrinx. And so if you don't know what a syrinx is, do I have a pointer? Here we go. A syrinx is a fluid-filled cavity, a cyst, and some people with spinal cord injuries get them. And what can happen when you have the cyst is then you can have new symptoms. So again, as a physician who sees people with spinal cord injuries, if the person tells me, you know, doc, I've always been able to move my hands, but now, and I've always been able to feel midway on my waist, but now my hand sensation is kind of not so good, and it feels like I don't have as much sensation on my waist, I get worried, and the first thing I think of is that maybe there's a cyst in there and it's expanding. So we looked for people who had these types of cysts, and this shows the cyst being little and then getting big, and felt that these are people who were having worsening problems and would be candidates then to have transplant. So we want to, again, besides proving that it was safe and feasible, we wanted to see if we could help promote the science of fetal cell transplant and spinal cord injury, and make sure that we could have outcomes that were relevant to patients and to scientists. It was non-randomized. We wanted to recruit 5 subjects for a year for 2 years. The patients would, because they're getting this foreign tissue, we're going to get immunosuppression, and we're going to follow them up at regular intervals. Our outcomes were what I call physiologic to patient-centered. And the idea here is that if you want to see if the spinal cord is working, you want to do physiologic type studies. But if you want to see if it's working for people, you want to know what their pain is like, what their quality of life is like. So we ended up recruiting 7 subjects. They all had thoracic spinal cord injuries from anywhere from 12 to 31 years ago, and all had these cysts for either 2 or 17 years. And their symptoms varied, and the typical treatment for a cyst then is a surgical procedure. It's perhaps a detethering or putting a shunt in to drain fluid off. And patients had as many as 5 previous shunts. And the shunts worked for a while in some. So this is a description of the surgical procedure. Detethering means that the cord itself can kind of be adherent to the bony structures and tissue around it. Decompression means you drain the syrinx. And the graft sites where the fetal cells were placed had to do with where the syrinx were. Anyway, and then the graft was verified with ultrasound. So this is just a diagram of what was done from fetal spinal cord, minced up, test tube, injected into the syrinx cavity. And this is a diagram showing what we hope would happen, which is some useful connection from brain above to spinal cord below. And these are some of our subjects. And probably we'll need to do the dim light thing. So what you're going to see is this is pre-op, this is after 6 weeks, and this is after 12 months. And I don't know if you can appreciate that there's a big cavity here, a big dark area here, and that's where the fetal cells were implanted. And that dark hole is no longer there. And then at 12 months, the cyst has not reformed in patient number 6. And this is the axial cuts looking down on the spinal cord. And again, you can see this big dark hole is cyst, and then it's replaced with tissue which lasts for at least 12 months. Going too fast? Are there any questions? Okay, good. I'm probably behind already. Here's another patient, small cyst, implant. Maybe the cyst is coming back a little bit over here. Well, I actually think it is coming back. This is a close-up, again showing the cyst, and at least at 3 months, it looks like the replacement has at least stopped new fluid from accumulating. And this is the same story, hole filled. Okay, our goal therapeutically, the dream, I think, for all of us is return of function. I think the dream is not return of some function. I think the dream is return of normal function. But the goal of this project was people were declining. Could we stop the decline and level them out at least? If there's return of function, that's an extra bonus. ASIA is the American Spinal Injury Association. And basically what this is showing is that of these subjects, their scores are pretty flat. They're not declining after they've gotten the fetal transplant. And this is showing it in a different way. Motor scores, pinprick, again, is staying pretty stable with our subjects. This is time post-operative. This is, as with Dr. Kerr's rats, most of the subjects did not show a dramatic functional change. But one subject actually did show a pretty dramatic functional change. And this is a gait mat. And a gait mat is something that you roll out on the floor, and when someone steps on it, you can gather data from their walking. And what you see is there's these funny-looking steps, and look at this long footprint. That long footprint is a foot dragging. And 3 months post-op, you see normal-looking footprints. That's an illustration that the actual velocity of gait has changed from about 0.14 meters per second to 0.55 meters per second, and fast pace even more. What do you attribute that improvement to? Well, maybe it's the fetal cell transplant, but remember these patients had their syrinx aspirated, they had detethering, they had rehab, they had new attention to their difficulties. So it's certainly premature to say that fetal cell transplants caused functional improvement in these patients. The conclusions of the study at this point are that, in fact, transplantation to humans is feasible, that it appears to be safe, and the third is that although the cyst remains collapsed, there was reaccumulation of fluid in some subjects, so this probably isn't the definitive treatment for syrinx. I'm going to change to a new topic, locomotor training for spinal cord or body weight suspended treadmill training. And the main person that I'd like to acknowledge is Dr. Behrman, who's a PhD physical therapist, and this is her team and all the associations that have helped support this work. And I'm going to start just by reviewing the body weight suspended treadmill training. Okay, I think for all of the physicians and scientists here, we're kind of brought up with this idea that your brain was a computer and your spinal cord was telephone lines, and if you put a hammer and mashed the computer in the head, then the brain part wouldn't work so well, and if you cut the telephone lines, then the messages to the legs didn't work so well. And that there really wasn't much thought that after injury there was possibility of repair, particularly in the central nervous system. But there's been some very interesting animal work that, not only, but there's been some very interesting animal work to kind of change those assumptions, particularly in terms of walking and spinal cord injury. This is an illustration of some work with cats where the spinal cord is transected. It's cut in half. And yet, when you put these cats on a treadmill, over time, their back legs walk. Well, if you cut the spinal cord, what's making those legs walk? If you think that the spinal cord is simply a bunch of wires that takes the commands out from the brain out to the legs, well, there can be no brain commands going out to those legs to cause the walking to occur. And basically, from this work, I'm not sure if I said this already, you're putting these patients on the treadmill and they're walking as their hind legs walking is getting better. If you take them off the treadmill, the hind legs don't walk. We've come to the belief that there's circuitry within the spinal cord itself for reciprocal gait movement. And many of you may have known this anyway. When you take a young infant, you can stand up the infant and get its feet to walk, even though the infant can't walk. Well, over time that reaction will actually disappear, and then over time walking will reemerge, a willful walking. And so we think, or at least I think, that represents those spinal circuits that are already there inherently in the spinal cord. Why does the walking go? Early in life, part of what we're doing is we're myelinating our axons. So when an infant is born, their brain isn't fully myelinated, and so the messages don't all get down to the lower limbs. It takes time to develop that. So early, there's no connections. That walking circuit is free to express itself. Later, as connections start to come down, that walking is inhibited, and later, as learning takes place, then the walking is enabled. I apologize if I've wandered too far afield. So anyway, we think that there's motor circuits that are independent of the brain that are in the spinal cord. And so that you don't actually need the brain to do some kind of stepping motion. And we also think that the spinal cord can learn, that with proper training, the spinal cord can start putting out these stepping motions without the brain connected. Now, if you have a complete spinal cord lesion, having your legs walk without your brain connected doesn't help you very much, because actually you want your brain to tell you where to place those legs and where they need to go. So in humans, this type of work is translated as, it comes under different names. Locomotor training is probably the most proper name because it talks about the training and not the equipment to train, but most locomotor training comes with a body-suspended treadmill. I'm going to show you a picture of a body-suspended treadmill in a moment. And actually, let me see if I can get to there next. No, all right. If I do this, will it go backwards? Let's find out. No. Okay. Now I broke it. How do I get that to disappear? Hit another button. Okay. God. Where's my hammer? I'll keep talking while I try to figure this out. So let me review a few studies of body-suspended treadmill training, and then I'll tell you a little bit more about the training itself. End show. Help.
You don't want to end the show?
No, let's go. Can we go to previous?
Yeah, I think so.
Okay. So let me talk about what body-suspended treadmill training really means to people. Typically, if somebody's been rehabbed and they don't have their normal walking back, our good therapists and our good physicians and our good team will try to get you up and going. And what we'll do is we'll give you assistive devices like a walker and braces, and instead of walking in your normal upright posture, we'll have you lean over on something. We could probably bring the lights up again. We'll have you lean over on something like a walker and teach you a whole new way of walking. Well, that whole new way of walking is not naturally encoded in your spinal cord. It's a new learned cognitive motion, and it works pretty well. But as you load your arms, there actually is probably inhibition of the spinal cord circuits for walking. So, for instance, when I ordinarily load my arms, like I'm leaning on the podium, the lectern, this is a lectern, when I lean over on the lectern, I don't want my legs to start moving underneath me. In most life, when you load your arms, that's actually not a good time for your legs to move. So in normal rehab training, if you're walking with a walker, you're likely to be bent over. Again, normal walking is upright. Being bent over probably doesn't excite the locomotor circuitry in your spinal cord. So the idea with the treadmill training, and I'll show you a picture of this in a bit, is we keep people upright. They have a harness underneath to help keep their body weight suspended. We put them on a treadmill. Therapists actually help place the feet, and as the treadmill moves underneath. This treadmill training goes slow. It's not a fast, normal walking speed. And what we're putting in then is normal sensation, where instead of putting the abnormal gait patterns that a rehab program will give you, which I'm not saying is a bad thing, it's just this is a different thing. We're going to try to restore the sensory messages into the spinal cord to help get that spinal circuitry to start produce walking again. I'm going to plunge on ahead. So I'm going to just talk very briefly about some studies in this type of training. This was an article by Vizentin et al. Where this type of training was used with 100 stroke patients. 50 got standard treadmill training and 50 got the body weight suspended treadmill training. And basically those with the body weight suspended treadmill training looked better at 6 weeks. They had improved balance, improved motor recovery, improved over ground walking speed, and improved walking endurance. And some of these improvements were still evident at 6 months. For spinal cord injury, I'm going to talk about two studies very briefly. These have both been in the literature in the last month or two. Here's one, and I think this is from the Miami project, combined use of body weight support, functional electrical stimulation, and treadmill. So they took 19 patients with an ASIA C spinal cord injury. They trained them for 1.5 hours a day, 3 days a week for 3 months. That's a lot of training. And they not only use the body weight suspended treadmill, but they use functional electrical stimulation, a triggered stimulation to the perineal nerve to help the swing phase of gait. And they also saw improved overground and treadmill walking speed and improved treadmill walking distance and improved lower extremity motor scores. A third, using just treadmill training alone, this was with only 3 individuals. Again, a pretty intensive treatment of 12 weeks, and they saw improved gait endurance, improved energy, cost of ambulation. There are many other studies on treadmill training that whether it's stroke, whether it's spinal cord injury, whether it's Parkinson's disease, this type of training has been helpful to restore gait in patients with central nervous system problems. I mentioned the Asia classification. I'm not very good at remembering scales, but usually one end of the scale means normal and the other end of the scale means horrible. And then you only have to remember 3 in the middle and what direction the scale goes. Of course, I would think that normal would be A, but normal is E. So D is a little not quite as good as normal. C is less good than that. And the actual classifications are here and in your handout. So there's actually now a randomized trial of treadmill training for acute spinal cord injury. It's multi-center and it's run by Bruce Dobkin, and I believe he's UCLA. And this is what treadmill training looks like at the University of Florida. This is Dr. Behrman, and this is the treadmill. The treadmill is helping suspend the weights, and we're keeping the patient upright. This is a gentleman with a spinal cord injury. Dr. Behrman's helping place the feet. Other therapists are helping guide the patient. The rods, now we're showing the patient with improved walking outside of the laboratory, and the rods are to help his hands move in a reciprocal fashion. Dr. Behrman, and I'm aiding Dr. Behrman in one of her studies. The criterion is Asia C or D type of spinal cord injury, less than 3 years after the spinal cord injury. You need to be able to walk 30 feet and up to 30 minutes a day. And it's actually a 9-week protocol. And we're trying to see what are the components of the treadmill training that are most effective. And this particular part that we're trying to look at is speed of treadmill, a factor in the efficacy of treadmill training. We have some other studies, one for balance after incomplete spinal cord. This one actually is a study that is done in a day. And this study is to compare another type of reciprocal training, cycle ergometry versus treadmill training. I'm going to switch gears. This stuff that I'm going to talk about is really my tribute to Jim Lubin, who many of you know. He's really a remarkable person. I'm sure he would have been a remarkable person if he never got transverse myelitis, but I wouldn't have known about it. And he is a ventilator-dependent individual and has constructed the beautiful TMA website. So this is, for those of you that aren't interested in, who are looking for a time to stop paying attention and aren't interested in ventilators, this would be a good time. Mechanical, MV is mechanical ventilation. How big a problem is this? This is a big problem. At our hospital, we had almost 1,500 adults on the ventilator for some period of time. These aren't all spinal cord injured adults. And actually, 9% of them were on for more than 21 days and accounted for almost 50% of the total ventilator days. And it costs a lot to keep someone on a ventilator. It costs about $3,500 a day. What makes it hard to, well, I'm going to talk about 3 types of things in this next piece of the presentation. The relationship between dyspnea, which is shortness of breath, and respiratory function. What happens with inactivity for skeletal muscle related to ventilation, and the effects of mechanical ventilation on respiratory muscle strength and function. So let's talk about dyspnea for a minute. Dyspnea is the subjective sense. It's your sense of discomfort in breathing. Where does this sense of dyspnea come from? It's got psychological factors, cardiac factors, pulmonary factors. It has to do with the shape of your chest and pre-existing pulmonary disease. And it really has to do with the difference between the demand to supply ratio. So most of us are not aware that we're expending effort to breathe most of the time. And that seems to be in part because our normal muscle capacity is way above the amount needed to breathe. And so that ratio seems to have a lot to do with dyspnea. You can make dyspnea occur if your total strength of respiration decreases. So even though you're still breathing down here with a low demand, this percentage of total capacity to breathe is increased because your maximum has decreased. And lots of things can cause this overall decreased muscle capability, spinal cord injury or many other factors as well. You can also make life more difficult by having a worse breathing function, whether that's from lung hyperinflation from emphysema or a whole host of other problems that might occur, including neuromuscular weakness from spinal cord injury. And the worst is if you have both of them. So the perception of respiratory effort, we think, often contributes to failure to wean someone or get someone off mechanical ventilation. We think that patients often fail spontaneous breathing trials. When someone's on ventilation, how do you get them off? Usually in some fashion or another, you actually take them off the ventilator for a period of time, see how they do, and then if they do okay, they can stay off longer. If they don't do okay, you put them back on. As they fail, patients typically get dyspneic. Well, that dyspnea, we think, has to do with the difference between how much work they have to do compared to how much work they can do. Why is it hard? What happens when someone's on a ventilator? Well, what happens when you rest? When you don't use muscles, they atrophy. And this is true whether it's skeletal muscles in your legs or the diaphragm in your breathing muscles. And these are just studies that show that. So I'm going to actually brush by them, and you'll take my word for it. Okay. And we lost that, and let's just keep going. Here's another study. So what we've done is we've done something called inspiratory muscle strength training. And I apologize, I forgot to bring the trainer with me. But what it is it's a valve. It's an air piece with a valve with a spring in it. Now there's two ways you can train. There's two types of training you can do. You can do it with orifices that change size, or you can do it with the valve. The trouble with the orifices is that the patient figures out pretty quickly, if it's hard to do, that if it's just a small opening, well, if I breathe slower, then I don't meet as much resistance. So we think the spring valve, which is independent of rate of breathing, is a better way to do the training. And we think that if you can strengthen your maximum breathing, then you decrease the dyspnea and you make it easier to come off the ventilator. So we've done this in the ICU, and what we see is we had 4 medically stable patients on mechanical ventilation, 1 patient up to over a year. Now these are patients that got on the ventilator following abdominal surgery. The training with this valve is basically one of our therapists comes along and says, "Mr. Jones, how you doing?" Mr. Jones has to be able to breathe a little bit off the ventilator, but they can't breathe a long time off the ventilator. And they say, "Okay, Mr. Jones, give me your maximum inspiratory effort." So Mr. Jones goes, and we measure that. And then we set our training threshold to be 50 to 75% of that maximal effort. This is strength training, not endurance training. If you work out at a gym and you want to get stronger, you have to go to really 50 to 75% of a maximal contracture. There are other breathing protocols that are endurance. Let's see how long you can go. But we think that actually doing the strength and increasing the strength of the diaphragm is a critical issue here. So we do several repetitions of that a day. And of these patients, all were weaned with 12 to 18 days of training, and none went back on the ventilator. One of these guys was on a ventilator for more than a year. The mean maximal inspiratory pressure increased from 18 centimeters of water to 44. So we really strengthened them, we got them off. I don't know if my explanation about dyspnea is why they got off, but that's our explanation so far. The patients are getting off. Who should get inspiratory muscle training? Well, it's a lot easier if a patient's medically stable, if they don't have progressive worsening, a fulminant disease that's worsening. And for us to train them, we need them to spontaneously breathe at least 1 minute. And you can sum that up as stable, alert, innervated, and motivated. It's not always easy or comfortable to breathe this hard, particularly if you've been on mechanical ventilation for a long time. And if you're not interested or motivated, we probably won't succeed. We've done a little bit of work in spinal cord injury, and we have a pilot project going on now. We've had 3 subjects. We have with each of these subjects, increased their maximal inspiratory pressure. And for each of these subjects, we've improved the amount of time they can go without being on the ventilator. But we've failed so far with these 3 to get any of them completely off the ventilator. Why have we failed so far with the 3 that we've tried? One is that perhaps the length of time, perhaps there's something about spinal cord injury itself, or the length of time being off, being dependent in breathing, that has caused long-term neuromuscular changes that make these patients non-amenable to treatment. I think another possible factor is that many of these patients are on baclofen. Well, baclofen suppresses respiration and suppresses the brainstem. And part of what we saw, at least with one patient, is we could get him off the ventilator, but we couldn't get him to spontaneously breathe. He could breathe for 4 hours off the ventilator, but he had to think each breath. His brainstem never took over and did the automatic breathing for him. And after 4 hours of thinking about his breathing, he had kind of had enough. So there may be, we may need to approach the brainstem differently. Maybe we haven't trained him for long enough. The next steps, we're going to do further work with the chronic spinal cord injured patients. I think we can combine therapy. There's a lot of medications that might be helpful. And maybe if we can get these patients earlier, we might be able to do well for them. So respiratory muscle strengthening is a promising but as yet unproven treatment. But there aren't a whole lot of other treatments out there. I'm going to switch gears again, and gears is probably the right word to use here. Those of you who know me know that I'm passionate about proper wheelchairs, and I'm excited when there's something new and better for patients in wheelchairs, and there's something better coming. Current wheelchair options are basically you can be in a manual chair, and that could be a rigid chair or a folding chair. You can be in a power chair. That could either be a scooter or a power-based power wheelchair or a non-power-based power wheelchair. Refer to the tapes from our last symposium for a further explanation of these. Manual wheelchairs. Advantages. They're lightweight. You yourself provide the power to push them. They're relatively easy to transport in a car. You can do all the adjustable seating that you'd want, and you get cardiovascular exercise from using them. Disadvantages. Well, you can't really go farther than you can push it. And the place that I really learned about this was when one of my medical colleagues with a spinal cord injury who was doing very well wheeling in the hospital and in the building next to us came to me for some assistance. I said, wow, you're wheeling well. And she says, yeah, I can wheel in my normal environments, but what happens when I have to go across campus? So a lot of wheelers actually, I think, limit their lives to how far they can go by pushing. And the other problem with manual wheeling is that over time there's emerging evidence that you get destruction of the shoulder and carpal tunnel syndrome from the repetitive stress. The traditional solution is a power wheelchair. Power wheelchairs don't cause you to use any effort, but they're hard to transport, they're heavy, and they enforce rest. And I just told you that rest isn't really a great idea for muscles if you can use them. So there's a new solution out, and this is called Power Assist. These are manual wheelchair frames with small motors and batteries, and the motor is actually engaged when the user pushes the push rim. So ideally, this type of chair would expand your access. You would really go not by just how far you could push, but by how far you could push with the help of the motor. You're still going to put input into your pushing. I don't think it's just cardiovascular that makes this important. I think that for those who can, it is a sense of being connected to the world and to the earth by your hands, and the proprioceptive input that you get from pushing is all valuable and worth preserving if we can. And the Power Assist can add as little as 25 to 30 pounds to a chair, so the chair can remain relatively transportable. There are three designs of this coming out. One is available now. The others hopefully will be out within the year. Albers makes a chair called the E-Motion. This is the only one that I believe is available in the U.S. now. And here's some pictures of the E-Motion. Again, can you see that well enough? Do you want lowered lights? Okay. The Albers system you can choose from 25%, a setting that's 25%, or a setting that's 50%, or a setting that's 75%. And so every time you push the wheel, it'll give you a little bit, it'll give you more power, and you can set that power. And the battery here is actually part of the wheel hub. Yamaha has a system that's been available in Japan and will probably come to the U.S. through Quickie. There's actually been a study on this. I've seen the galleys of this study. It should come out in the archives of physical medicine sometime soon. Basically, in a test of wheelers, they did show reduced energy demand, reduced heart rate, but they weren't very excited about the chair. And they did find it more difficult to disassemble. You'd expect that because it's got more to it. Why weren't they more enthusiastic about it? Well, I think part of the reason is that they were relatively healthy spinal cord injured patients who were active already, and that the lab environment may not have been challenging enough for them to see the true advantage. The third system is one that we're researching called Delta Glide. It's out of Connecticut. It has a variable ratio power assist, and we have actually tested a total of 1 subject with this system. Again, I don't know if you can see, but this is the motor all here. You can't see the battery because it's tucked underneath the seat. We've lost an illustration. Okay. Well, you'll just have to take my word for it that the bursts of EMG are greatly reduced when patients are using this on inclines or carpet. The picture that was there would have showed big scratchy lines every time the person pushed when they used their own chair, and very little scratchy lines when they used the power assist. And that's another, this one's carpet, the other one was incline. Okay, last topic that I'm going to talk about, and I have 8 minutes and 53 seconds left to go, so I'm doing good, is psychological and immunological effects of massage and spinal cord injury. And this is a work that I worked with Dr. Rogers at Ohio State. And basically, in spinal cord injury, separate from having the injury, as a consequence of having spinal cord injury, there looks to be altered immune response. What are some of the evidence of the altered immune response? Well, patients or people with spinal cord injuries get increased numbers of urinary tract infections, respiratory tract infections. They have slow healing from ulcers. If they get hospitalized, they're likely to stay in longer than someone who would be hospitalized for the same reason who didn't have a spinal cord injury. Well, we always thought that that was all due to the dysfunction from the spinal cord injury and not the immune system itself. But and I'll talk about that in a second. There's been studies, and actually Ohio State was one of the places where this type of science of neuroimmunology was founded, that there's evidence that being under chronic stress lowers your immunity. So actually being under momentary stress, humans look pretty well set up for. So the bear comes and we either stab it or run away. Our systems are good at gearing up for that. But if the bear follows us around all day and all night, we don't have good mechanisms and we kind of wear down. And when I was at Ohio State, as a medical student, they were testing this out on medical students. And I'm not making this up. They would test certain medical students that were accepted to the study would have their blood tested before they took a test and then after they took the test. And before we took the test, when we were up all night for the last 3 days, all our immune markers went down. And after the test, hopefully before we found out our scores, our markers returned to a more normal state. Spinal cord injury appears to be a state of chronic stress with depression of the hypothalamic pituitary adrenal axis. Now, if stress causes immunity to go down, and if spinal cord injury is like having a bear follow you around, then what makes stuff get better? Well, let's take a look at massage. These are actually documented massage benefits. Decrease in anxiety, increase in alertness. There's been a study showing improved math computation skills, lower cortisol and norepinephrine levels, and men with HIV showed improved natural and adaptive immunity following massage. So we wanted to see 2 things. One, it actually has been shown in acute spinal cord injury that immune markers go down. But what happens after someone's had a spinal cord injury for a long time? And then we wanted to see what would happen in spinal cord injured patients before they entered a month-long treatment of massage. That wasn't just one massage, and after a month after the massage ceased. So we had 17 individuals with spinal cord injury. They were all at least 1 year post-injury, and no other complicating factors. And to tell whether chronic spinal cord injury depressed immunity, we compared them with 15 aged and gender-matched healthy controls. And it was a pre and post design. I've talked here a little bit. The massage was provided 3 times a week for 60 minutes. And it was a standardized massage protocol. We actually rotated. No patient got the same therapist every day. We made sure that every patient got all massage therapists, so we didn't get a therapist treatment effect. And the outcomes are listed, the immunological outcomes, which I'll talk about in a moment. We did the profile of mood states to look at their adjustment and the FIM, functional independence measure. And let me go on from here. So before anyone got a massage, when we compared the normal controls versus the spinal cord injured patients, the spinal cord injured patients had higher interleukin-2, an indication of T-cell activation, higher cortisol and CAMP indicating sympathetic activation, or that fight or flight activation, lower lymphocyte proliferation. Well, you need lymphocytes to fight infection. White blood cells weren't different between the groups. So having a spinal cord injury looks like gives you a different, and these people were healthy otherwise, didn't give you a lower, having a spinal cord injury does seem to chronically give you a different immune profile than normal controls without a spinal cord injury. So this is showing what happened to, now we're looking at our spinal cord injured patients before they had the massage compared to after, compared to 4 weeks after that. Lymphocyte counts. Before massage, they're low. After massage, they become significantly higher. And then post 4 weeks after that, they go low again. Lymphocyte proliferation, the ability to mount an attack, is low. After massage, it gets raised higher. 4 weeks after massage, it goes low again. Cyclic AMP, part of this sympathetic activation system, was high. After 4 weeks of massage, had gone lower, and then returned high after massage ceased. Cortisol levels, another measure of the same type of thing, same pattern. This was really interesting. The patients that we drew from were largely spinal cord injured patients who were active in sports. So when we looked at the profile of mood states between the spinal cord injured patients and the controls, these active spinal cord injured patients actually had lower scores on the anger and hostility subscores and vigor activity than the normal controls. So they were probably a little bit more psychologically healthy and more adjusted than the controls. So what's ever causing this immune dysfunction, it doesn't seem like it's depression that's causing the immune dysfunction. These don't look like depressed people. But with the massage itself, the anger and hostility scores actually went lower, and the tension and anxiety scores, subscores of the profile of mood state, went lower than they were. So this would be more healthy, we assume. And afterwards, they actually rebound higher than they were before they had gotten a massage. So I think they're kind of pissed that they're not getting massages anymore. Things that we didn't look through in this study, we didn't compare cervical injuries to, do cervical people respond differently than thoracic level injuries. We didn't look at what part of the massage was most helpful. Was it just meeting with someone who was nice to you? Was it the physical massage itself? Was it the social support? And there was a considerable amount of individual variation. This study hasn't been published and is kind of in a chronic state of getting published. So we think that massage could be an effective method of improving general health and wellness in the spinal cord injury. I have to say that these blood levels of immunity aren't the end story. If your blood levels change but you get the same number of urinary tract infections and respiratory tract infections, then who cares? We have to show that really that an intervention like this would actually improve the actual physical functioning and health. Patients did report, though this wasn't a measured outcome, that a couple of them reported, gee, I can move my pinky that I couldn't move before, and we're kind of like, I don't know if we want to see this. This has scary implications. And others had said that their tone was reduced. That isn't so scary. We think massage reduces tone. So I think I've said pretty much all I wanted to say. I have 10 seconds left. So here's the acknowledgments for that study, and I'm done. Thank you for your attention. And I have 4 seconds for questions.
We're scheduled for a coffee break. If people have questions, you want to take a couple questions now, or otherwise during the coffee break.
Was this a full body massage or just a?
It was a full body massage over the. The question was it full body? Yes. Over the whether the person was over sensate and insensate parts. The control group didn't get massage. They were simply a control to look at the baseline. That's a good question. I'm sorry, go ahead. Can massage activate spasm? I didn't actually see the massage taking place, but I think those of you who have spasticity, anything can activate a spasm. So I don't see any reasons why massage wouldn't, but in general, it seemed to have an overall decrease on spasticity.
When I have massage, it's not activated at all.
Okay.
It's actually not.
Yes? I heard that the use of baclofen can suppress breathing. What was after that? Well, I think this is to be a topic of great discussion as to the benefits and possibly deleterious effects of medications that we use in patients who have spinal cord injury. If you're not having trouble with breathing on baclofen, I wouldn't discontinue it because of that possible side effect. If you're having trouble breathing and you've had a spinal cord injury, there might be reason to review your medications and might be reason to change from baclofen. I'm sorry, you already answered one. Yes.
I'm interested in I can do some walking around here, but I live in a residential community where there's no golf, so a golf cart is a little stupid. But, and I'd like to possibly go on a walking path. Is there anything that you can assist since I don't have the endurance to go long ways and I'm pretty much stuck in the neighborhood?
The question was, I don't live near a golf course, so I can't use a golf cart, and I want to go on walking paths. If you can certainly use power if you just want to go on them. If you can't wheel as far as you want to go, there's really 2 solutions, and you want to wheel. One is to get a better wheelchair. Wheelchair weights can go down to 17 or 16 pounds. You don't use a wheelchair. That's a complicated question. Basically, people's endurance can be improved. Almost everybody's endurance can be improved by doing endurance exercises. It's hard for me to say for you in particular. There's no particular device to make you walk longer. Okay. I have one more question, and then I have the look of the moderator that I have no more questions.
When your peers get finished, where will that study appear?
Where will that study appear? I don't know yet. One place, you're talking about the massage study? One could be in the proceedings of the meeting of the Second Transverse Myelitis Association, if there was a proceedings, or another possibility would be the American Journal of Physical Medicine and Rehab, or someplace else. Thank you very much.